Thank you, Dr. Rohit, for those kind words. I'm afraid there's going to be some overlap between my talk and Dr. Dade's talk because the topics were such that can't be helped. But I'll try to be as brief as possible. I'm talking to you all about Pearls in strabismus surgery. So Pearls, while planning surgery, there should be no shortcut to preoperative assessment. So preoperative assessment is the crux of your surgical success. There's no shortcut. You can't just see a patient a day and operate him the same day. It's never done. So you have to see the patient once, twice, thrice before you are sure that the angle is the same, the movements are what you feel they are, and then assessment should be that perfect. The assessment should be. The larger deviation would give more correction per millimeter of surgery than a small angle deviation, and although the same deviation would have the same surgery would have more effective in children than in adults. Then patients with fusion potential can be slightly overcorrected, and patients with fusion potential should be undercorrected. Surgery should always be aimed at static angle of the squint and not at a dynamic angle, because whenever there's an partially accommodative esotropia, the static angle would be a particular angle, and if you see them without spectacle correction or see them with less of spectacle correction, the dynamic angle is going to be more. And so if you operate at a dynamic angle, you're going to land up with a exotropia. Then appropriate non-surgical techniques like proper refraction, orthoptic exercises, management of amblyopia, which could eliminate the need for surgery, should be carried out before deciding upon surgery. Now, this girl appears to have a esotropia, which increases when she focuses on a particular object. And after giving glasses, her esotropia is less for distance. And again, there is some by focal glass. So should be processed before we decide for surgery. The most important thing is counseling of parents. You should be on the same page with the parents, or if the patient is adult, with the patient. We all know that most of the times we need to do a bilateral surgery, but sometimes the patient feels that only my one eye is squinting, and why is that the doctor operated both my eyes? So all this should patient have a happy and happy patient and an understanding patient, and to avoid the litigations and all those things. So counseling is of utmost importance. You have to tell them the length of treatment in a squint. Most of the parents feel that if surgery is done, everything is all right. But I always tell them that surgery is only part of the surgical planning. It is not the treatment as such. So one has to make the patients aware, because they are totally unaware about what the problem is and how is the length of treatment. So counseling, if you spend more time with the children, with the patients, parents, and the patients before surgery, the lesser headache it would be for us afterwards. The Pearls 7 is when we are doing surgery. So force junction test is very important. Force junction should be done at all the stages of the surgery. Before we start the surgery, after we do conjunctiva is cut, after the muscle is cut, after the suturing is done. So force junction test is very important. I would just like to give a small example of this child who had presented with exotropia with prominent eyes and loss of adduction, and there was a retraction of the lids on adduction. So one felt that it had a tight lateral rectus, and accordingly the surgery was planned. But on doing the forced junction test, on doing the forced junction test on the surgical table, the forced junction was quite free, and so we explored the medial rectus, why it was so, and we found that the medial rectus was hypoplastic. So the reason for loss of adduction in this patient was not a tight lateral rectus, but it was a hypoplastic medial rectus. So the management totally changes. So one has to do forced junction test at all the stages. So the resection of a muscle is more effective when done simultaneously than when done at different times, as has been stated by Dr. Dade. While reinserting the muscle, the width should be maintained. It is absolutely mandatory because central sagging would mitigate the result of your planning. Anti-segment ischemia is possibility when we are operating 3 recti, especially if one of them is LR. So you have to do a staged surgery or muscle sparing. One has to respect tenons. It would lead to post-op adhesions, especially when we are operating 8 to 10 millimeters behind the muscle insertion. Again, sclera is thinnest at the muscle insertion, and one has to be very careful while taking the sutures while doing the resection procedures. While working on the oblique or vertical muscle, one has to be careful of vortex veins and nerve to the inferior oblique. Again, infant eye has different dimension as compared to the adult eye, and posterior segment is underdeveloped. So surgery, if you go beyond the arc of contact, is unpredictable, and one has to keep this fact in mind while operating. Surgical plan should be based on the patient's record, and the eye should be clearly mentioned. Then when we are doing resurgery, one should get more, try to get as much of history as possible, because in our country, in our place, the patient just walks in without any discharge card, and there's nothing, no record with the patient. One has to look for scars on the conjunctiva, and whenever possible, use an adjustable suture. I'll just tell about one case before I close. In this case, the 30-year-old female had come with a large angle exotropia with history of surgery being done twice, first on both the eyes and second on right eye, but no records. Examination showed scars over the medial recti on both the eyes and right lateral rectus. So accordingly, one had to guess that the medial recti of both the eyes were recessed. Of course, now we have modalities to image the muscle, which will tell you the location of the muscle, but sometimes it's not possible. And so in this case, we found that the medial rectus was attached about 11 millimeters, which could be brought, and we could, yes. So these are the pictures, and thanks for a